will be very clear and nice. بس من هلا I want to advise you guys to use first aid when you study. يعني whenever you study about a disease, go to first aid, read about it, so that when you prepare for step 1 later on, it will be very easier. Much easier.
And when we get to the pharma point, sketches is really good as well. Sketchy micro, sketchy pharma, I don't recommend those.
And start from now solving AMBOS questions. Try to get used to solving questions من هلا. Because I started doing this in GIT in year 2 semester 2. This made me, لما هلا I'm revising GIT, it made me revise it in 1 week. Okay? Cardio, I don't remember anything because I didn't do that. My advice is يعني start this as early as you can.
As for AMBOS questions, يعني they are usually hard. So it's good to, if you train on them, you'll find other things easy by the way.
Like we start with patho first, the esophagus lecture. أول شيء, the doctor added these definitions. You should know them. Okay, heartburn, it means a burning sensation in the chest. Dysphagia is difficulty swallowing. This is difficulty, phagia is swallowing. So dysphagia, difficulty swallowing. Hematolysis is vomiting of blood. And odinophagia, this is not in your lecture, but yeah, you should know it. Odino is pain, so pain while swallowing. Now we'll start with the actual diseases. The first disease that the doctor talks about is tracheoesophageal fistula. And you should know that atresia means a complete blockage of a tube. تمام? أما fistula is the connection. Can I use the pen? Okay. We have 3 varieties of tracheoesophageal anomalies. تمام? We have pure esophageal atresia, pure tracheoesophageal fistula, and the combination. This combination is the most common type. Pure atresia, you can see here that the esophagus stops here and nothing can enter the stomach. That's why on X-ray you will find a gas in the stomach. There's no air in the stomach. Amma, these other 2 types, because they're connected to the trachea, any air that the baby breathes will reach the stomach. Okay, so the gastric bubble will be very prominent. I'll show you an X-ray later. And they also, in fetal life, they present with something called polyhydramnios. What does this mean?
A lot of amniotic fluid.
A lot of amniotic fluid. This happens because the baby is not able to swallow the amniotic fluid. Usually the baby is floating in the amniotic fluid. Amniotic fluid is made of the baby's urine. A part of the processes that balances the amount is by swallowing it. If there was an atresia in the esophagus, nothing can reach the stomach, so nothing will be swallowed. The amount of amniotic fluid will become increased. تمام؟ هلا, to differentiate these 2 types, what you can do is insert a nasogastric tube. Do you know what it is? Nasogastric tube. It's basically a tube that they insert it through the nose all the way to the stomach to provide nutrients, and for those who can't swallow or they have difficulty swallowing. In esophageal atresia, the nasogastric tube will stop here, so the doctor cannot insert it all the way to the stomach. When you look at this X-ray, if you look here, because this baby has a tracheoesophageal atresia, the nasogastric tube will stop here and it will loop and go back.
Okay.
While in the actual one, the normal, if you look here, this line is the nasogastric tube. It went all the way down to the stomach. So failure to insert it can also indicate that the patient has an esophageal blockage. تمام? هلا we move on to esophageal rings and webs. What you need to know about this is only 2 things: the location and how it looks, and also this syndrome. How it looks, the rings is a complete circle in the esophagus. It causes command dysphagia, difficulty swallowing. And the webs, it's just a partial circle. It's not a full circle. Webs happens more in the upper part of the esophagus. The rings happen more in the lower part. Okay? Rings can be a complication of GERD. There's this syndrome called Plummer-Vinson syndrome. It's basically a triad of iron deficiency anemia, dysphagia, and esophageal web. So there's this mnemonic: Plumber's dies, D for dysphagia, I for iron deficiency anemia, and E for the esophageal web. And this syndrome, if you ever diagnose a patient with it, you have to follow them up because they have an increased risk of developing squamous cell carcinoma of the esophagus. Okay, this is not mentioned in your lectures, it's something that you should know. Next, we have achalasia. Achalasia, whenever you see this sign on X-ray or barium swallow. This is a barium swallow. Basically, they give the patient contrast to enhance the GI tract. But you will find it, there's a very prominent narrowing here. This is called the bird beak sign. Okay? Why does this happen? In achalasia, there's failure of the lower esophageal sphincter to relax. This happens because the myenteric plexus, as you know, it's the nervous tissue between the muscular layer and the esophagus. It causes peristalsis normally. And how does peristalsis happen? By releasing the relaxing peptides, nitric oxide and VIP. In this disease, there is degeneration of these neurons that release these inhibitory ones, so peristalsis cannot happen. The esophagus itself cannot widen down. So what happens is that the lower esophageal sphincter will stay constricted. So anything that the patient eats, it will stay locked here. They will have difficulty swallowing. At first it will be solids only, and then it can progress to liquids as well. Okay? And because the food stays in this area, they will have a lot of irritation of the esophagus. This can increase their chance of squamous cell carcinoma. We'll talk more about cancer later, but it's basically because of absent peristalsis. Basically, A means no, achalasia, I think it's peristalsis, or movement, yeah, movement. So there's no movement. Why does it happen? It's mostly idiopathic, okay? But a secondary cause is Chagas disease. It's a cause of parasite. Just know this name for now. Dr. Ibrahim added more causes in red, please read them. Diabetic autonomic neuropathy, malignancies, and abnormal tissue deposition like in sarcoidosis, amyloidosis, etc. Okay? Now, if you have any questions, you can stop me, okay? Next is the hernias. We have mainly there are two types. But three other types, 3 and 4, they're low yield and usually you don't get questions about them. We have sliding hiatal hernia and paraesophageal hernia. The difference between them is the part of the stomach and the lower esophageal junction where it is. In the sliding hiatal hernia, it will be displaced upward. Also, the cardia part of the stomach will be upward. In the paraesophageal hernia, the lower esophageal sphincter it's at its own level, but only the fundus of the stomach went upwards. Okay? Which one increases the risk of GERD? The sliding one, yes. Good job. And yeah, that's it for this part. The other two types, we have type 3 is the mixed type, where both the cardia and the fundus, as well as the lower esophageal sphincter, all go up. And type 4 is due to a short esophagus, so even the abdominal contents can go upward and herniate upward. But these last two are not that important, okay? I'll explain the diverticula. Only this one is mentioned in the esophagus lecture. This one is in the small intestine. But I like to explain them together because they're very related, okay? First of all, know that we have two types of diverticula. We have a true and a false diverticulum. The true diverticulum is when all layers of the lining protrude outside, okay? Like in the Meckel's diverticulum. In Zenker, it's a false diverticulum. False means not all of the layers go out. Which layers go out only? Mucosa and submucosa. And yeah, so in Zenker diverticulum, what happens is the inferior pharyngeal constrictor muscle is composed of two parts. The thyropharyngeal part from the thyroid ligament to the pharynx, and the cricopharyngeal part from the cricoid ligament to the pharynx. There's an opening, slight opening between them. If the wall was weak and there was this motility of this muscle, what will happen is that the mucosa and submucosa can herniate outwards. And this causes this outpouching. Dr. Ibrahim likes to call it Zenker diverticulum from KFC. You eat Zenker and you have a bad breath. Because this causes halitosis. Okay? When food stays inside this sac, okay, it will rot over time and it will cause a bad breath. Also, when this mass expands, it causes this failure. Yeah. It happens in older people. Meckel diverticulum, on the other hand, it's because of persistence of this vitelline duct. This vitelline duct is a connection between the midgut and the yolk sac in the embryological period. Normally, in adults, this sac, this outpouching will obliterate. It should stop. Okay. If at part of it stays persistent, it will be called Meckel diverticulum. Now, what's important about this is that it can have other types of tissue within this diverticulum, like gastric mucosa and pancreatic mucosa. And what's important about this is that gastric mucosa inside the intestines, it secretes acid, the gastric mucosa. And the intestinal area, it's usually an alkaline environment, so this can cause erosion in this area and it will cause bleeding in the stool, okay? So if you see a baby with bleeding in the stool, it might be due to Meckel diverticulum. This disease follows the rule of twos, so not all of it is really important. It's two times more likely to occur in males, it's 2 inches long, 2 feet from the ileocecal tract, 2% of the population. It's a common congenital anomaly. But the two important ones are it presents in the first 2 years of life, and it has 2 types of epithelium. It can have 2 types of epithelium, the gastric and the pancreatic. And this is important because it can lead to what? Bleeding in the stool, blood in the stool. Also, Meckel diverticulum, because it causes an irregularity in the intestines, it can lead to obstruction. It can also lead to intussusception. We'll talk about it later, and volvulus as well. Okay. Any questions so far? No. I'll talk about Mallory-Weiss syndrome. It's basically longitudinal tears inside the esophagus, mostly at the lower third. They happen because of vomiting. When someone vomits a lot, there will be increased pressure in this area, and this can cause these tears. Who does this happen to mostly? People who have alcohol use disorder, and people who have bulimia nervosa. Do you know what bulimia is? Yeah, exactly. Those people who they have this psychological disorder about their weight. What they do is whenever they eat, they feel guilty about eating a lot, but they cause themselves to vomit on purpose. All of this can lead to pressure in this area and cause these tears. It's called Mallory-Weiss syndrome. Usually it only affects the mucosa and submucosa. If all of the layers of the esophagus were affected, there will be a perforation. The perforation is called Boerhaave syndrome. Okay? This syndrome is not in the lecture, but it's very important. If it happens, the air and the stuff inside the esophagus can go to the mediastinum, and mediastinum is a sterile area, so there shouldn't be any bacteria, any other particles in that area. That can lead to sepsis. It's an emergency, okay? As you can see here, feel a bit of air in the mediastinum in areas that it shouldn't be there. And whenever you see something like this, it's a surgical emergency. You should always, it will be an emergency. This happens, most of the common cause of this is iatrogenic from endoscopic procedures, but it can happen with violent retching. Retching is the same as like forcing vomiting, okay? And it affects all the layers of the esophagus. As you can see, this is Mallory-Weiss syndrome, only the mucosa and submucosa, while Boerhaave syndrome, all of the layers get affected and there will be perforation. Okay? Next, I'll talk about varices. Okay. So our body, the way most of the tissues get drained are through 2 systems. Portal system and the systemic venous drainage, okay? So, most of the GI tract, the venous drainage goes to the liver directly, okay? And after the liver, through the hepatic veins and to the IVC, inferior vena cava. But some areas have double areas of drainage, okay? The esophagus itself, the lower part is drained through the left gastric vein to the portal vein. But this is the way blood usually flows, like this direction, okay? And also, there's another way for the esophagus to drain, is through the submucosal veins to the azygous vein, okay? And this connection, through the azygous vein, it goes directly to the inferior vena cava, while the left gastric goes to the liver through the portal vein. نفس الشيء around the umbilicus. This is the umbilical area. These veins, they drain to the inferior vena cava directly. superior epigastric, these, you'll take them more in detail in anatomy, okay? As well as the rectum. The rectum is the third area. The superior rectal vein drains to the inferior mesenteric vein to the portal system, and the middle and inferior go directly to the IVC. Okay? هلا, if there was blockage in the portal vein, in the portal system, portal hypertension, what will happen is that the blood cannot go to the liver, but it will try to find other ways to reach the inferior vena cava, to reach the heart. What will happen is that the flow that usually goes like this, it will try to go to the other ways. فإذا is a horn canopy blockage, the blood that cannot go through like this, it will go to the other way, which is the through the azygous vein, and the submucosal vein of the esophagus to the azygous vein. نفس الشيء here. And when we were little in the, embryologically, we had the umbilical vein here that connects to the umbilicus to the liver. Usually, it becomes the ligamentum teres, so it should be obliterated. إذا كان في severe portal hypertension from cirrhosis or other causes, this vein can open again, and the blood that cannot reach the liver, it can go like this, and it can go like this, okay, to the paraumbilical veins and cause another symptom, which is caput medusae. نفس الشيء in the rectum. The blood that cannot reach to the superior rectal vein to the portal system, it can go through the other way through the IVC and cause hemorrhoids. Here you can see dilated submucosal veins. These are called esophageal varices. Okay, they usually happen in the lower third of the esophagus. It's the area where the connection happens, and this is very life-threatening if it ruptures because a lot of blood can cause the patient to die. Okay, it happens in severe cirrhosis. This is how caput medusa looks like. The veins will be dilated like this.
Can I ask a question?
So,
Okay, I will have the other half of the lecture, but I really wanted to say something really quickly. For esophageal varices, Dr. Ibrahim really likes to mention a story for every single batch. Who died? Okay, Doctor. Yes, if you know Abdulhadi Mohamed, he is an Egyptian singer. He died from esophageal varices rupture. He likes repeating the story.
This singer, he had schistosomiasis infection of the liver, caused cirrhosis, and then he developed this and died because of the rupture of these varices. هلا esophagitis. Dr. Ibrahim has divided them into three categories, four. This one I don't consider it esophagitis. There's chemical types, there's infectious types, and because of GERD, the erosive one. Chemical due to alcohol, due to hot drinks and all of that. Infectious, CMV, HSV, Candida. These happen in mainly immunocompromised people, okay? GERD and reflux Barrett's, it's because of acid regurgitation back into the esophagus, so it will cause erosion in this area, causing inflammation, esophagitis. Lastly, Barrett's, we'll talk about it later. GERD, it's basically a disease caused by the reflux of acid from the stomach into the esophagus. And whenever this happens, the main typical symptoms would be heartburn and regurgitation, okay, and dysphagia. They can present with other symptoms. We'll talk more about this in the hospital part. They can also have chronic cough and hoarseness. It will lead to erosion in this area, and this area, the esophagus, the lower part of the esophagus, it's usually lined by which type of mucosa?
Stratified squamous.
Stratified squamous. Non-keratinized. If acid reflux kept happening for a long time, a metaplasia can occur, which is Barrett's esophagus. The epithelium will change from non-keratinized stratified squamous epithelium into intestinal columnar epithelium, which is non-ciliated columnar. There's also goblet cells in it. It's intestinal, not the stomach type, because goblet cells are not found in the stomach. Why does this happen? It's to try to balance the acidity that keeps coming from the stomach. So the esophagus tries to make it less acidic by differentiating into a different cell type that can withstand this acidity. Like in the duodenum, it's the first part that receives the acidity of the stomach, so it has a lot of goblet cells to secrete alkaline mucus and like that. The esophagus here, it will differentiate into this type, and this is precancerous. It can lead to esophageal adenocarcinoma. It's not cancer yet, it's just metaplasia, but it has a high risk of developing into adenocarcinoma. And this is how it looks like. I will show you the normal line, the junction between the stratified and the columnar of the stomach. It's very clear. It's called the Z line. If there was Barrett's esophagus, you can see it looks like this. The junction اختفى, and the stomach and the pink. حكى على فكرة. There was a question in our exam. Salmon colored. شو اسمها هي؟ distension of the esophageal line. It's Barrett's esophagus. Okay. فkeep this in mind. آخر شيء. For this lecture, we'll talk about the types of esophageal cancer. It's divided by region. The upper 2/3 of the esophagus, it's by squamous cell carcinoma. It gets squamous cell carcinoma. The lower third, adenocarcinoma. Why does the lower third happen, the adenocarcinoma? It's usually complications of GERD and acid reflux. Chronic GERD, Barrett's esophagus, obesity because the increase in the mass can cause the acid to reflux easier, and smoking is present in all cancers. The squamous cell carcinoma, it's mainly caused by irritation of the upper 2/3 of the esophagus due to alcohol, hot liquids, smoking, achalasia, okay, and nitrosamine-rich foods. And lastly, this picture is important. First, the esophagus is lined by squamous epithelium. If inflammation kept happening, esophagitis at first, and then it can become Barrett's esophagus, metaplasia, and then dysplasia, and then carcinoma. I have now some questions. Who wants to try to read?
A new imaging modality is being tested to study vitelline duct morphology. A fetus at 20 weeks gestation is found to have partial obliteration of this duct. Which of the following is the most likely sequela of this condition?
Before you read the options, what do you think is...
This is the diverticula and Meckel?
Yes, Meckel is diverticula. So, which one?
Bleeding from the
Bleeding from the gastrointestinal tract too. Why does this happen?
because of the gastric mucosa.
This diverticulum can have gastric mucosa. It can erode. Next one. Who wants to try? The girls? No? Adi, if you understood what I explained, تعرف تجاوب. حدا منكم بده؟
A 69-year-old man comes to the physician because of progressive difficulty swallowing and a 5-kilo weight loss over the past 3 months. He first had trouble swallowing solid foods, and then also developed difficulty swallowing liquids over the past week. Endoscopy shows a large mass 3 centimeters proximal to the esophageal gastric junction. Biopsy of the mass shows significant distortion of glandular architecture. Which of the following is the strongest predisposing factor of this patient's condition?
What does he have? Esophageal. Which cancer? Adenocarcinoma. Okay. So what increases the risk of adenocarcinoma?
Ask them.
Into. I just mentioned it.
Adenocarcinoma was the
lower third.
The lower third. So chronic GERD, obesity. So visceral obesity. Yeah.
Yes. So next, this one you don't need to read the question. من الصورة you can know.
Yeah.
Absence showing cantal absence of the peristalsis.
Yeah. Which disease was this? Bird-Beak sign. Achalasia. Okay. So which of these options? Can you read them? واضحين?
Atrophy of the esophageal smooth muscle. Presence of intracellular مش ما intracellular basophilic inclusion, infiltration of eosinophils in the epithelium, absence of أتوقع أول واحدة.
Absence of atrophy of smooth muscles, or it's more related to nervous structures.
أوكي معناتها المفروض دي.
D. Absence of the myenteric plexus in the neurons. Yes, it's D because in achalasia, the myenteric plexus would lack the neurons that are responsible to release VIP and nitric oxide. These ones they cause a relaxation. Okay. Now we'll move on to stomach. هلا أول شيء I want you to know the parts of the stomach. This is the cardia immediately under the esophagus. The fundus and the body are here. And lastly, the thyroid part is this. I'm mentioning them لأنه the type of gastritis affects a certain area of this. هلا أول شيء the stomach secretes acid that can actually melt حديد, iron. Okay. How is our body not digesting itself? It's because of these defense mechanisms. From mucus lining of the stomach to prostaglandins that decrease the acid production, and they also increase mucus secretion. So if someone was taking NSAIDs, the NSAIDs, they lower the prostaglandins. That's why it can cause increased acid production and less mucus secretion. It can also lead to ulcers over time. Okay? Also, other causes of injury, H. pylori infection, aspirin, cigarettes, alcohol, all of this. We'll start with some general definitions first. Erosions and ulcers. Erosions affect only the mucosa, but it doesn't penetrate the muscularis mucosa, which is the last layer of the first, it's the last layer of the mucosa. Okay, so it doesn't reach the submucosa. Ulcers, they reach the submucosa. That's the only difference between them. Gastritis, we have two types, acute and chronic. The acute one is acute, يعني it happens fast. It's due to NSAIDs. NSAIDs used can decrease the prostaglandins that provide protection for the stomach lining. They increase the mucus, they increase also blood flow to allow, to protect the stomach, right? Burns can cause just acute gastritis because hypovolemia can decrease the blood flow to the stomach. The blood will be diverted to more vital organs like the brain and the heart. So burns can also cause ulcers, as well as brain injury. These two examples, they're not in your lecture, don't really worry about them. No NSAIDs use can cause acute gastritis, okay? It's mainly among those who take NSAIDs for a long time, like people with rheumatic arthritis, and people with alcohol use disorder can also have this. Chronic gastritis is divided into two types, okay? The doctor has them as type A and type B. Type A is the autoimmune type that affects parietal cells. It causes antibodies against parietal cells and the intrinsic factor. So with the absence of intrinsic factor, which vitamin will be deficient?
B12.
B12. So the question can describe someone who has peripheral neuropathy because of vitamin B12 deficiency, and the reason might be because of autoimmune chronic gastritis. Type B is B bacteria, so it's because of H. pylori. H. pylori, it can lead to peptic ulcer disease and mild lymphoma. It affects the antrum of the stomach. It's called H. pylori because this is the area that it affects of the stomach, the pylorus part. And because of the variance factors of this bacteria, the proteases, the elastases, it can lead to inflammation of the stomach. In the autoimmune type, because the parietal cells are the ones that are affected, they release HCl, which is the stomach acid. Which hormone would be increased in order to compensate for this? Sorry?
Hormone to compensate?
Not compensate exactly, but as a reaction. هلا in autoimmune gastritis, parietal cells are affected, so the acid secretion will be less. Gastrin will increase, yes. And they might have even gastric area hyperplasia. So gastrin in the autoimmune will be increased to stimulate the parietal cells to increase HCl. So parietal cells are the ones that are affected in this. هتلاقوا gastrin levels high in the autoimmune type. But they may be normal or decreased in the H. pylori. Okay? طيب. Yeah. About the areas affected in the stomach, the H. pylori one affects the pylorus part, the atrium. The autoimmune affects the body and the fundus because this is the area where parietal cells usually are in high concentration. Okay. Peptic ulcer disease. It's mainly caused by H. pylori bacteria. Which part of the GI system is most affected by this?
Duodenum.
Sorry?
Duodenum.
Duodenum, exactly. The duodenum, it's the one that's mostly affected by it, and it can also affect the stomach, but to a lesser extent. But if you see any ulcer in the duodenum, immediately think of H. pylori. Okay? There are other causes of peptic ulcer disease, like cigarette smoking, high dose of corticosteroids, and all of these. But mainly, no, H. pylori is the main one, and it causes these ulcers. These ulcers in the stomach, they might look. The duodenum has ulcers as well, okay? But duodenal ulcers, they're rarely malignant. In the stomach, if you see an ulcer, it might be just because of peptic ulcer disease, but it can also be because of cancer. Because gastric cancer looks a lot like the ulcer caused by H. pylori. But when they do an endoscopy of the GI system, if they find any ulcer in the stomach, they should biopsy it. If it was in the duodenum, it's rarely biopsied because it's always never malignant. In the stomach, it can be due to gastric cancer that we'll talk about later. In gastric cancer, the borders of the stomach will be raised, and it would be larger than the ulcer caused by H. pylori. فهلا, do you guys understand what I'm saying? I will repeat. H. pylori infection can cause ulcers in the stomach. There's also gastric cancer in the stomach. It can look like the ulcers caused by H. pylori. So how do we differentiate it? We should do biopsy. Any ulcer in the stomach, it might be cancer, it might be peptic ulcer disease. In the duodenum, it's always H. pylori. So, something about peptic ulcer disease is that the location of the ulcer can affect the type of pain that happens. Is that the pain is greater when someone takes meals? It's mostly gastric. If it improves with meals, it's duodenal ulcer. Do you know why this happens?
Because of secretion of bicarbonate on meals, alkaline.
Yes. So if someone has a gastric ulcer, the ulcer is in the stomach, and whenever they eat, the stomach will start releasing acid to digest the food. But this will cause the pain of the ulcer to increase. If the ulcer was in the duodenum would release bicarbonate. The duodenum, when someone eats, the pyloric sphincter will also be closed to digest the stuff in the stomach. But no acidity will reach the duodenum at first. That's why when they first eat, in duodenal ulcer, the pain will go away. Okay? 90% of the duodenal ulcers are caused by H. pylori. Gastric ulcers is 70%. Other causes of gastric ulcers are NSAIDs, that you should know. And for duodenal ulcers, if you find any ulcer in the duodenum, it could, most of the time it's H. pylori, but the patient had Zollinger-Ellison syndrome. It's basically a disease where there is high gastrin levels because of a tumor. This tumor secretes gastrin, so there will be high acidity. High acidity can cause even ulcers in the duodenum, and it may reach the jejunum. If an ulcer reaches the jejunum, usually jejunum doesn't have ulcers. But because of the syndrome that increases acids, an ulcer can happen there. فبس تشوف an ulcer in the jejunum, it means it's due to Zollinger-Ellison syndrome. Duodenal ulcers, as I said, they're generally benign, so not routinely biopsied. The gastric ulcers, the risk of carcinoma would be high, so they are usually biopsied to rule out malignancy. I want you to see this X-ray and tell me where's the abnormality. All of them are for the same person. Look at this one,
There is air under the diaphragm.
There is a lot of air.
Okay, so what is this sign called?
Pneumoperitoneum.
Pneumoperitoneum. It's also similar to the one that happens in esophageal perforation. Okay, but it's also life-threatening. It's a surgical emergency. This is a complication of ulcers. If the ulcer was on the duodenum, that's anteriorly, the most likely complication to happen is this perforation. If the ulcer was on the duodenum, that's posteriorly, posterior to the duodenum, there's the gastroduodenal artery. The complication of that would be hemorrhage. Gastric ulcers, they're usually on the lesser curvature of the stomach. So this causes bleeding from which artery?
Gastric.
Left gastric artery. Okay, next we have the gastric cancers. I'll explain it on this and then we'll go back. Usually gastric cancer is almost always adenocarcinoma. Okay? Adenocarcinoma of the stomach has two types. There's the intestinal type and there's the diffuse type. The intestinal type looks like an ulcer and it has raised margins and with central ulceration. It's mostly at the lesser curvature of the stomach. The diffuse type, it's called diffuse, so the whole lining of the stomach is affected. Okay? So the stomach lining will look like a bag of leather. It's called linitis plasticum, this sign. And microscopically, you would see these types of cells, the signet ring cells. The signet ring cells, we got a question about it, okay? Know that it's present in the diffuse type only, okay? And yes, the mutation caused by the diffuse gastric ulcer is called E-cadherin dysfunction. Okay, this is the mutation in this gene, E-cadherin. But the intestinal type, it could be from other genetic mutations like P53 or FAP or APC genes. Okay, and H. pylori causes mostly the intestinal type, not the diffuse type. Okay. Next, we have the diffuse type of gastric cancer. It can metastasize to the ovaries. Okay, but if you see bilateral ovarian tumor, it's called Kronkenberg's tumor. It might be a metastasis from the gastric carcinoma, the diffuse type, this one. Okay, the one that has the thick stomach lining, the one that has the signet ring cells. If you find them also in the ovaries, it might be due actually to gastric cancer that went to the ovaries. Okay, مفهوم this part? The intestinal type, it's usually, if it metastasizes, it's called Sister Mary Joseph nodule in the umbilical area. Okay? So other signs of gastric cancer are these two signs. The lesser Celiac sign or severoid keratosis. It's just like diffuse brown patches on the back. And acanthosis nigricans, which is darkening of these areas of the neck and the axilla as well. Now we move on to questions. Yes.
45-year-old man comes to the emergency department because of a one-day history of black tarry stools. He has also had upper abdominal pain that occurs immediately after eating and a 4.4 kg weight loss in the past 6 months. He has no history of major medical illness but drinks 3 beers daily. His only medication is acetaminophen. He is a financial consultant and travels often for work. His partner had a positive urea blood test 2 weeks ago and was prescribed medication. Physical examination shows failure and mild epigastric pain. Esophageal gastroduodenoscopy shows a bleeding 15mm ulcer in the antrum of the stomach. Which of the following is the strongest predisposing factor for this patient's condition?
Okay, first of all, what's happening here?
Black tarry
There's
stool.
positive urea breath test. There is black tarry stool. There's pain that appears after eating immediately. So you suspect which type of ulcer?
Gastric.
Gastric ulcer. And it's also, we mentioned there's an ulcer in the antrum of the stomach. Which of these risk factors is most likely to cause it?
Helicobacter pylori infection.
Yes, good job. There's this question as well. Who wants to answer? اختار أنا. تفضل.
Iftifar then comes to the physician because of a 3-week history of intermittent and running epigastric pain. His pain improves with antacid use and eating, but returns approximately 2 hours before following meals. He has a history of chronic osteoarthritis and takes ibuprofen daily. Upper endoscopy shows a deep ulcer located on the posterior wall of the duodenal bulb. This ulcer is most likely to erode in which of the following structures?
So, which artery is most likely?
Gastroduodenal?
Yes, gastroduodenal artery. So, if the ulcer was on the anterior duodenum, what will happen? Pneumoperitoneum, perforation. Posterior is hemorrhage. Yes.
I just want to add something that you can cancel guys. يعني most of them don't make sense أصلا. They are not related to the duodenum. But you can cancel the
Yeah. لما you answer the questions, first read the last part, look at the choices على السريع, and then read what's happening in the question, so you can answer it faster. There's also this last question. هي شوي difficult. بس إذا مركزين معي والله بتعرفوا الجواب. Who wants to answer? Oh, خلاص. Whoever wants to answer can answer.
A 42-year-old woman comes to the physician for the evaluation of a 1-month history of dull lower abdominal pain, decreased appetite, and a 5 kilograms weight loss. Physical examination shows no abnormalities. Pelvic ultrasonography shows bilateral ovarian enlargement and free fluid in the rectouterine pouch. Biopsy specimens from the ovaries show multiple round mucin-filled cells with flat peripheral nuclei. Further evaluation of this patient is most likely to show which of the following findings.
Right.
Okay.
Before you read the findings, can you tell me what you're thinking of?
Yeah, it's diffuse gastric cancer.
Yeah.
So he has gastric wall thickening as well.
Right. How did you know it's the diffuse type?
Because there is the mucin-filled cells with flat peripheral nuclei, which is the sigmoid ring. Sigmoid ring.
Good job. طيب. So the option is which one?
Gastric wall thickening.
It's the diffuse type of cancer. We'll continue. We'll move on to the third lecture. First, you should know about the ventral wall defects. They're basically problems or incomplete closure of the lateral folds of the embryo in embryological life. Now, this can manifest as 2 conditions, either gastroschisis or omphalocele. Which one is covered by peritoneum? Omphalocele. Which one isn't covered? Gastroschisis. Which one is, you can actually find the umbilicus?
gastroschisis. You can find
Gastroschisis, yeah. لأن الأمفالocele, the abdominal contents will permeate through the umbilical opening. Okay? And which one is associated with chromosomal abnormalities? Omphalocele. Trisomy 13 and trisomy 18. Okay? Next is the intestinal atresia. In your lecture, there's only duodenal atresia, ما في jejunal and ileal atresia. But it's good to know both of them. The duodenal atresia is basically هلا لما in embryological life, when the babies, يعني the intestines are being developed and all of that, they usually grow very rapidly. For the lumen would be closed at first, but then it should recanalize. If there was failure of recanalization of the duodenum, يصير في duodenal atresia. Okay, so it's basically blockage. The sign that's present on X-ray is double bubble sign. If it was jejunal and ileal atresia, it will be triple bubble sign. The double bubble sign, the first bubble is from the stomach, and then there's the narrowing because of the pyloric sphincter, and then the duodenal bubble, the duodenal enlargement. Okay? Yeah. The cause of the duodenal atresia, مثل ما قلت, it's failure to recanalize, but jejunal and ileal atresia, it's because of the disruption of the mesenteric blood vessels. When there is disruption of these blood vessels, there will be necrosis in a part of the jejunum, maybe, or the ileum. The body will resorb it and it will block this way. So that's why we could feel this atresia. Now, why did I add hypertrophic pyloric stenosis? It's not included in your lecture, but to differentiate them, you should know the first one. I'll show you an anatomy picture first. here we have the gallbladder and the pancreas. They both meet and they drain bile into the duodenum in here, in this sphincter of Oddi. But usually, if there was duodenal atresia, it would be after this point. For any type of vomiting that will happen, it will contain bile. It will be bilious vomiting in case of duodenal or ileal or all of these atresias. Thus, in hypertrophic pyloric stenosis, the blockage is before the area that drains bile into it. Bile actually drains here, but stenosis is actually here. Any food that comes here and it will be vomited, it will be non-bilious vomiting because it's not mixed with bile. Okay, that's how you can differentiate between both of them. And usually this presents a bit later. It presents in 2 to 6 weeks, while the first one immediately, 1 to 2 days after. Okay. So, the triple bubble sign is for jejunal atresia, double bubble is for duodenal atresia. And here, the doctor mentions some causes of intestinal obstruction. We have adhesions. Best truthful in the past, in the question, there was signs of obstruction, but they didn't mention anything specific except that the patient had surgery a few years ago. It's most likely adhesions is causing the obstruction. Okay, so basically it would obstruct the bowels. It can form these fibrous tissues, the intestine sleeve, and all. The other causes of obstruction, like hernias, volvulus, intussusception, inflammations. Okay, diverticula. I highlighted the ones that you should focus on. لأنه the rest okay, and tumors as well is also important, but the rest comes. Here we have abdominal hernias. Why would an abdominal hernia happen? What would be the problem?
Abdominal wall weakness.
Abdominal wall weakness. Usually it happens inguinal hernia or femoral hernia. They happen. Which one is more common in females? Femoral hernia. Males inguinal hernia. Okay. And the doctor didn't really mention a lot of details about this, but some complications of hernias are necrosis, vascular compromise, obstruction. Okay, and these can affect the bowels and cause obstruction and signs of necrosis, which is actually life-threatening, لازم يكون فورا emergency surgery. Volvulus is basically twisting of the bowel on the mesentery, on its mesenteric supply. Most of the organs are intraperitoneal. Intraperitoneal means there's mesenteric connection to them. Inside the mesentery, we have the blood vessels. But if there was twisting of the bowel, if it twisted, the blood flow to the segment would be affected. Okay? So this can cause also ischemia and necrosis. In sigmoid volvulus, there's two types: midgut volvulus and sigmoid volvulus. The doctor didn't mention and didn't specify these types, but know that midgut volvulus happens mostly in children. Sigmoid happens in adults. And what's the sign on X-ray? Coffee bean sign. This is how it looks like. It looks like a coffee bean. And this is basically sigmoid volvulus looks like coffee bean sign. Next we have intussusception. This is basically when a part of the small intestine, a proximal part, goes inside a distal part of the intestine. It usually happens where? In the ileocecal area. So this is the terminal ileum. This is the cecum. Because the ileum is a bit narrow than the cecum, when the peristalsis wave happens, this can get stuck inside, and this telescoping, it's called telescoping because if you look at the telescope, it's like layers inside. Okay? But this leads to intussusception. Intussusception can have some complications like vascular obstruction, and this can cause a specific type of stool, which is parent jelly stool. And most of the time the cause is idiopathic, but if they mentioned in the question that a baby got, recently they got the rotavirus vaccine, so the virus patches inside the intestines, they will hypertrophy. Any hypertrophy or any mass can increase the chance of this happening. Usually in children, it's mostly because of viral infections or a vaccine. In adults, the cause is tumors, but it usually happens in children. Now, a characteristic sign on ultrasound is this sign. It's called the target sign, where you can see like two big loops of bowel. It looks like a target sign, exactly. Okay. Any questions so far?
No.
Diagnosis. Wait. Jejunal atresia. Why? Three bubbles. Triple bubble sign. Jejunal atresia. Next, we have Hirschsprung's disease. Hirschsprung's disease is very similar to an esophageal disease. Which one? Achalasia, yes, Achalasia. Achalasia, in both of them, they have a similar presentation, but in different areas. In the Hirschsprung's disease, the colon is affected. In Achalasia, the esophagus. Hirschsprung's disease, there is basically no nerves of the Auerbach and Meissner plexus. The ganglion cells didn't migrate there. Okay. Ganglion cells, the ones that secrete those inhibitory neurons, the VIP and nitric oxide that can open and cause peristalsis, they wouldn't be there. The absence of these, it's mostly caused by failure of these crust cells, neural crust cells, to migrate to this area. So it's AID, okay. Meissner and Auerbach plexus, they contain what nerve fibers? These nerve fibers come from neural crest cells. If there was failure of migration of these cells to this area, it will cause Hirschsprung's disease. And how does it happen and how does it present? If there's a newborn baby and 48 hours passed without the baby passing stool, this is when you start suspecting this disease, okay? Next, we have, do you know the watershed areas of the colon?
Yes.
What are they?
Splenic flexure.
Splenic flexure and?
The rectosigmoid also.
Okay. And what's the significance of these, Yani? They have dual from the SMA and the IMA in the splenic flexure. And the rectosigmoid, there's from the IMA and internal iliac artery. If there was shock or hypovolemia or these complications, these are the areas that will get affected because they will receive the least amount of blood supply. Okay? Here, ischemic bowel disease, the doctor divided them into two types, mucosal and mural infarction, and the other type, transmural infarction. In mucosal and mural infarction, they're both caused by shock, hypovolemia. Okay, and the areas that are affected are which areas? The watershed areas. And the transmural infarction, it affects all of the layers of the intestine of the colon, and it's usually caused by acute vascular obstruction, like an embolus or a thrombus in that area. Okay. Next, the doctor added these two diseases in the lecture: angiodysplasia and hemorrhoids. Angiodysplasia is basically malformation of blood vessels or dilation, okay? And this can lead to blood in the stool, hematochezia. What's the difference between hematochezia and melanoma?
Hematochezia is the dark stool.
Hematochezia is the bright stool. Okay, it's basically lower intestine, lower GI bleeding. The upper GI bleeding would get oxidized, or it will present as black dry stool. Okay, and for step 1, you should know that it's also associated with aortic stenosis, von Willebrand disease, and end-stage renal disease. This is not mentioned in your lecture. You don't need to know it for now. Next, we have hemorrhoids. في فرق between internal and external hemorrhoids. Which one is painful?
External.
The external one, because it's supplied by which nerves? Somatic nerves. The internal hemorrhoids are supplied by visceral nerves, so they're usually not painful, okay? And yeah, hemorrhoids are basically caused by high dilated veins that I talked about, hemiciphy, portal hypertension. Hemorrhoids is also one of the associations. Celiac disease, it will be explained further in the hospital lecture, but you should know that it's an autoimmune mediated disease. People susceptible to it have HLA-DQ2, HLA-DQ8, and they usually present with the malabsorption. They have diarrhea, steatorrhea, weight loss, and mineral deficiencies. Which part of the small intestine is mostly affected in celiac? Which duodenum? Duodenum and the approximate part of the jejunum. So which mineral deficiency will happen? What gets absorbed in the duodenum? Iron. Iron deficiency can happen. Proximal jejunum, which nutrient gets absorbed? Folate. They can also have folate deficiency. On finding on serology, you can find also autoantibodies against IgA, anti-tissue transglutaminase, anti-endomysian, and anti-deaminated glycan. Though you know them more in biochem. Next, lactose intolerance. Basically, which enzyme is deficient? Lactase. They can't digest the lactose sugar that's found in dairy products. Okay. This causes osmotic diarrhea because the sugar that stays in the colon, it will absorb water from the intestine and cause osmotic diarrhea. That's the tropical stool. It's very similar to celiac. What's the difference? The area that's affected. Which area is affected in tropical stool? Jejunum, and it can be affected. But they present with megaloplastic anemia due to folate and B12 deficiency. And what differentiates it from celiac, it also responds to antibiotics. They didn't identify the cause yet, but mostly in the tropical regions, people who have malabsorption, they might be having this tropical stool. Okay. آخر شيء, pseudomembranous colitis. It happens because of overgrowth of which bacteria? Usually C. diff. Okay, this happens to people who take a lot of antibiotics, but their microbiota will get disrupted and it will cause overgrowth of C. diff. It can present as pseudomembranes. And what's the treatment for it? You took it. Oral vancomycin. It's one of the few indications of oral vancomycin. Also, vancomycin is not really absorbed orally. Usually it's given IV. But this is one of the cases where oral is given because you want to target the bacteria that's in the GI tract. Okay? Yalla, question. From the sign, you can know immediately without reading. What's happening? Duodenum. Double bubble. Duodenal atresia. Careful. And for patho, solve what path. I recommend you guys to solve what path, and these Dr. Ibrahim likes this website. Okay. Patient. Now we'll move on to the first hospital lecture. I added the slides that I think you'll have questions on them. First of all, know that gastroesophageal reflux. Okay. Gastroesophageal reflux is usually, it's something normal that can happen to anyone. The lower esophageal sphincter can be loose sometimes, causes mild regurgitation. Best is that it causes symptoms for a long time. That will change the diagnosis into disease. It will be now called disease. Reflux can happen to anyone, but the disease is only when it has these main symptoms or any other atypical symptoms. The main symptoms are heartburn and acid regurgitation. And it happens when the lower esophageal sphincter, when the anti-reflux barrier is disrupted. So this includes the lower esophageal sphincter. If there was a problem in it, it will increase the chances of GERD happening. Also, the crural diaphragm plays a role in preventing reflux, and all of these ligaments, and even the angle of this angle, it acts like a valve to prevent reflux of the acid from the stomach to the esophagus. These risk factors are important to know. I know Dr. Ali might ask you which patient has a higher risk. Think of the risk factors, which one has more risk factors in the question. They are females, obesity, sometimes physical activity can worsen the reflux. and smoking and alcohol, and advanced age, of course. As I mentioned before, one of these hernias can increase the chance. Which one? Type 1, sliding hiatal hernia. It increases the risk of having GERD and reflux. And the classical symptoms, if a patient came to you with classical symptoms, you start immediately by giving the empirical treatment, which is PPI for 2 months. Okay? So the classical symptoms, heartburn and regurgitation. But only half of the patients with GERD have this. What other ways can they present is with dysphagia or these rare symptoms like weight loss, odynophagia, burping. Older patients are usually more asymptomatic. They can also have pulmonary symptoms like chronic cough, aspiration, asthma, and sleep disorders. And because of the acid reflux, also the teeth can get eroded. There's also, you should know that GERD is a spectrum of diseases. It's not a specific disease. It can reach to erosive esophagitis, which is the most severe form, where a lot of acid exposure causes erosion of the esophagus. There's also this subtype, NERD, or non-erosive reflux disease, where there's acid exposure, but if you do an endoscopy, the endoscopy will show normal. Everything is normal. What's the gold diagnosis for the GERD? Gold standard diagnosis? 24-hour pH monitoring. Yes. So if you actually check pH monitoring for these patients, it will show that it's positive. Okay. There's also these also fall under NERD subtypes. They're basically لما يكون في reflux hypersensitivity. The patient is sensitive to the reflux. يعني بيكون reflux بس خفيف وnormal histology. آخر شيء functional heartburn. هاي كمان I don't think that's important. And you should know that if a patient comes to you with heartburn and acid regurgitation, you don't need to do any further testing. Start the medical treatment and follow up to see if the patient improved or not. Okay? Complications of GERD, hemorrhagic esophagitis, and ulcer perforation, peptic esophageal strictures, Barrett's esophagus that leads to which cancer? Adenocarcinoma. And aspiration pneumonia. Before we move on, I want to show you this mind map is done by someone in our batch, Amin. Okay, how to deal with someone and with a presenting complaint that's similar to GERD, and how do you proceed further? أول شيء, if he came with classical symptoms, heartburn and regurgitation, what do? You start with treating them. Okay, depending on the frequency of the treatment, if frequency of the symptoms, if it was 2 or more per week, GERD is usually diagnosed, and you'll start empirical treatment with PPI. If it was less than that, you can just tell the patient to do lifestyle modifications or start them on H2 receptor antagonists which are less potent than PPI. And then follow up. If the patient's symptoms are relieved, yes, you confirm GERD. If not, you can shift to another PPI or increase the dose and then follow up again. If the patient's symptoms got relieved, GERD is confirmed. If not, you do an endoscopy. After the endoscopy, if it was abnormal, it is GERD. If it wasn't normal, you do the pH monitoring. If it was positive, it is GERD. Which subtype? Non-erosive. هذا الendoscopy كان normal. But pH monitoring confirmed that there is acid reflux. Okay, and you can start with the treatment plan. Amma negative, now you start thinking of other differential diagnoses. Okay, but if the presenting complaint was atypical symptoms, okay, they can be either GI related or extra esophageal. If they were GI related, like nausea, burping, hiccups, it follows the typical way of diagnosing GERD. You start the treatment and you follow up. If it was not GI related, you do pH monitoring for 24 hours. If it was negative, consider other differentials. But positive, GERD is confirmed. Okay? Other indications for this is before surgery to confirm that the patient actually has GERD, so you don't do a surgery that's unnecessary for the patient. But if the patient came to you with these alarm symptoms, you should immediately go do an endoscopy. The alarming symptoms are dysphagia, odynophagia, painful swallowing, weight loss, vomiting, and GI bleed. This is to rule out cancer, okay, and other Barrett's esophagus, and yeah. Okay. If the endoscopy was normal, you consider other dimensions. If it was abnormal, GERD is confirmed, and you start with the treatment like usual. Halla, I'll show you a question. Who wants to read?
Okay. A 20-year-old man with non-bronchial asthma is referred for further assessment due to a persistent nocturnal cough despite optimized treatment. He denies having heartburn or regurgitation, but complains of hoarseness and frequent throat irritation. Which of the following should be recommended next to confirm a diagnosis of gastroesophageal reflux?
So the patient came with atypical symptoms, chronic cough, okay, and throat irritation. So what do you do next?
Endoscopy.
Endoscopy? Okay, wait. Are these symptoms alarming symptoms? Are they like weight loss, odynophagia, dysphagia?
No.
No. So you don't immediately do endoscopy. It's very invasive. You do something else.
C.
pH. Request 24 hours pH monitoring to confirm if there was acid reflux. Okay? Everything clear? I'm done with my part now. Atef can continue. Thank you.
Assalamu alaikum, everyone. Okay, it has been a long day, so I'll try to make it quick. So I'll be doing the second half, or less than a bit of a half of the lecture. I'll be going over the second hospital lecture for celiac disease. Then I'll go through the pharma lectures, 2 pharma lectures, okay? So I'll be changing things up a bit, so it becomes more like exciting. It will be a question-answer based format, and we will see how well you guys do, okay? So, first question. Which of the following is the most common and related risk factor for developing celiac disease?
A.
C.
Is it C or A?
A is more common.
Both A and C.
Okay, let's see. Yeah, but I'm talking about more common according to Dr. Ali's lecture. Okay? DQ8 is in the remaining. DQ2 is in 90% of people, okay? If you have this or this, okay, you can have a possibility of getting celiac disease. Everyone who has celiac disease has one of these mutations, but not everyone who has one of these mutations has celiac disease, okay? So keep that in mind. And some other epidemiological genetic factors. Okay, moving on to the next question. Who wants to read this question? صح.
Patient presents to the clinic with no symptoms or anything, but he is
Or anything? Okay, never mind.
But he is worried about developing celiac disease because his sister has it. What's your next step? I think B.
It's
Genetic testing.
genetic testing or serology testing? B or C? What do you think? C, right? The correct answer is C, yes. In actually the majority of cases, you go with TTG antibody. Why? If you want to go with genetic testing, it's pretty expensive, it's pretty readily unavailable, and it's not that specific, okay? So what you do is usually, in most cases, you go with the transglutaminase, okay? Why didn't we go with the IgA endomysium, EMA?
Not readily available.
No, but both of these have like a good amount, but
Yeah, but more common is the IgA.
generally when we have, I mean like why not D?
D. Yeah, C is more common. The TTG.
Yeah, well, it's better in terms of like results for specificity and sensitivity. If you don't have it, then you go with D in the other choices, okay? Really important. So that's like the general algorithm for a low probability. You go with TTG antibody. And then positive, you go with an intestinal biopsy to check for like the MASH stage, we'll get to it. Negative, you exclude the diagnosis, okay? Question 3, who would like to read this?
I do. A patient presents to the clinic with iron deficiency, bloating, loss of weight, and blue stool. An intestinal biopsy is performed and it shows loss of villi and crypt hyperplasia. Which of the following types of celiac disease does she most likely have? Iron deficiency, so anemia, so atypical.
Typical.
Okay, how many people say typical? Raise your hands. How many people say atypical? Raise your hands. Okay, let's see. For typical symptoms, you have weight loss, nutrition deficiency, diarrhea, statutory, okay? Atypical, that's where the bloating and these things come, okay? So it's atypical. It's atypical, yes.
But can you go back?
Yes, sir. These
There's loss of weight.
iron deficiency,
There is
bloating.
There's loss of weight.
Okay.
Anemia with bloating.
Okay, look.
Iron
But not
deficiency
iron
is malabsorption.
Iron deficiency would cause iron deficiency anemia, so atypical disease.
I think he meant because of having bloating also. Bloating is atypical.
Wallahi, when I get to these questions, I remember the Dr. Ali explains really well, but his questions are a bit difficult. So I will.
So Dr. Ali wrote this question? ولا؟
المهم, I cannot accept or deny this statement.
Nutritional
but-
deficiencies, iron deficiency, weight loss was written in the question as well.
And there was loose stool as well.
Okay, but it is iron deficiency what? Iron deficiency anemia, right?
No,
Yeah.
only iron deficiency. It is anemia, of course.
Yeah. Top.
I think
Okay.
it's a
What did I say?
atypical, one atypical sign, it immediately means that it's atypical.
Yeah.
One sign is enough for it to be atypical.
Yes, we have bloating. That's a classic atypical
Yeah.
sign, okay?
Maybe it's alarming.
If it combines
Yeah.
both, so go with atypical.
Yeah.
Look, atypical sign is there, go atypical.
Okay.
Otherwise, go typical, okay? Who would like to read this question?
A patient presents to the clinic with Hashimoto's thyroiditis and megaloplastic anemia. You want to screen them for celiac disease. Which of the following tests would you perform? C.
C? Is everyone agreeing with C?
Yes.
Okay, it is correct. Yes, it is C. Again, this is another algorithm. Previous algorithm, it was the autoantibodies, the TTG. Here, we have another algorithm with moderate to high. Again, we go with TTG. And here is another algorithm with baseline serology. Again, we go with TTG eventually. But here, that's a different one. I'll get back to it in another question. It's important to note that there are some diseases that have a definite association with celiac disease, and some of them have probable association. What we mean here is research has proven that not necessarily when this happens, that happens, but there is definitely a link between them, and some of them maybe there is a correlation, but we are not sure if it's a direct causation or not, okay? So these ones in red, they are important to know, okay? In the lecture, Dr. Ali put them. These ones are really important to screen for celiac disease when they have them, okay? Because you will find some things here, regardless of that. Ignore Down syndrome for a moment. The other ones, you will find a lot of them have an autoimmune version, okay? So with diabetes mellitus type 1, it has an autoimmune factor in it. Diabetes mellitus type 2 is not related, okay? So he could ask you in the exam, bring diabetes mellitus type 2, which one is not related to the lecture, okay? It's DM type 2. Dermatitis herpetiformis is a very characteristic extra intestinal feature of celiac disease. Question 5. I think it's pretty repetitive at this point, right?
B.
B.
Wait, okay.
Do you all agree it's B? Yes, it's B again. I need to really emphasize this point, okay? The others, okay, we may have for the others, we have for gliadin, we have anti-gliadin, we have anti-endometrium, we have anti-tissue transglutaminase, but HLA-ATQ is not related, it's a genetic thing. But keep in mind the highest sensitivity and specificity is for tissue transglutaminase, right? Then you can go with endometrium. If tissue transglutaminase is not in the question, then you can go for gliadin, okay? Yes, here is the human TTG followed by the endometrial antibody. Again, the doctor specified it that way in the lecture, and the AGS have the least. It's important to note that there is another thing that's a bit more recent called the deamidated gliadin antibody, which has a strong factor as well, but it's not used as much as the anti-TTG. However, in some specific cases where you really want to rule out celiac disease or find if it's not, and you are really on the edge, a lot of things so that it's not celiac disease, but you really want to make sure, sometimes you do an anti-TTG and an anti-TBG, which is this one. Okay, but again, it's not that readily available. Doctor didn't specify it that much. Which of the following foods is most safe to eat in celiac disease patients? Corn, yes. Why not oats?
He said oats has a gliadin.
There is a reason why oats. No, it's not necessarily this. Yes, there is usually a cross-contamination when farming goes. Okay, so when you go to this Darwinian tree, you will find for the grains, wheat, rye, barley, ignore this, okay? These are really bad for them. Oats, they are a bit farther, but again, not that far, and there could be cross-contamination. Rice and corn are pretty safe to use, same with the other two, okay? Keep in mind, you will find an interesting correlation in epidemiological studies where in countries where there is a major reliance on wheat, you will find more prevalence of celiac disease. While in countries like in Southeastern Asia, in China and stuff, where they use more rice and corn, you will find less prevalence of celiac disease. It's an interesting note. Question 7. A bit of a different format, so I hope you keep an eye out for it. Who would like to read this? Okay, okay. This prompt will be repeated multiple times, okay? This is the question. You think it's C? Everyone agrees it's C? Does everyone think it's C?
C.
C. Okay. Does anyone know what the first one is for?
No.
Okay, we still didn't study it in chemistry. Huh? Yes. Okay. So for the adult presentation of, it's because the prompt has a presentation. Okay, keep in mind here the doctor is talking about classical presentation. He's not talking about typical or atypical. I got confused a bit. Okay. While researching for this. So here, for example, you will find, if I can find here, some atypical signs. For example, severe hypokalemia causing muscle weakness. But I'm not talking about typical adult presentation. I'm talking about classical adult presentation, which may have some atypical features. Okay, that's for the adult presentation. For childhood presentation, which can also happen, we have some different features. It's important to note failure to thrive. So they do not achieve their growth parameters as expected. And that's because of the because of the malabsorption and stuff. Okay. They may also have rickets and stuff with the bones and other symptoms which directly relate to the malabsorption, especially for vitamins, minerals, and stuff. Question 8. Same prompt. Just read. According to the patient's endoscopy, which of the following is the Marsh classification, Marsh stage? If you remember, I will get to it in the next slide. Does anyone know? Stage 2. What does he have here?
I don't know the rest.
What does this indicate here?
Stage 1.
It is stage 1. Okay, what does stage 0 indicate?
Nothing.
Okay, what does stage 2 indicate?
Hyperplasia.
What does stage 3 indicate?
Atrophy.
What does stage 4 indicate? Okay, what does stage 5 indicate?
Stage 5.
Okay, good. You got it. Okay. There is no stage 5. So stage 0 normal, stage 1 IELs, lymphocyte infiltration, stage 2 crypt hyperplasia, glass atrophy, and then even worse atrophy, okay? It's complete destruction, stage 4. Question 9. A 50-year-old male complaining of stomach cramps, flatulence, and weakness is evaluated clinically. Upper GIT endoscopic biopsy revealed villus atrophy and lymphocytic infiltration and damage to the epithelial layer. Which of the following is the most probable cause of this disorder? Okay, so we are getting into some pathology here. I think Maram discussed it. I believe so. So, yani, a lot of these things, I think this is a bit of a tricky question.
Conversion of glutamate to glutamic acid.
No. It's C, yes. I'll get. The doctor didn't discuss it a lot in details. It's important to know that there are, we discussed genetic factors before. Here are some environmental factors of the disease. What were the genetic factors? What were the two HLAs we discussed? DQ2 and DQ8. DQ2 being more common. There are the environmental factors which are exposure to wheat proteins, primarily gliadins. Okay. Keep in mind here, gliadin is here.
I don't understand why.
But I will say it now. And genetic factors we already discussed. This is where it comes from, the immune factors. Okay, so there is a slight wrong. There is slightly something wrong in each of the answer choices except for C. Okay. So, for example, inability of digestive enzymes to break down alpha gliadin. That's not necessarily the case. The enzymes are there. Okay. Do you need a description for each one? Or?
No, only E and C.
Okay. Let me go to the... By the way, it's not really related to this. I saw the notes. The doctor said do not focus really that much into this, right? It's more of immune, right? Yeah. Okay. So just keep that in mind. It's an important question. Keep it in the back of your head, okay? Question 10. This is also a good question. Keep it in the back of your head. A 27-year-old man complains of chronic foul-smelling diarrhea for the past year. He has no nausea or vomiting. On physical examination, there is no abdominal pain or masses, and bowel sounds are present. His stool is negative for occult blood, upper GI endoscopy, blah 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 blah. Which of the following therapies is most used for this man? Okay, what we are discussing? Celiac disease. We are asking about treatment here. Okay. Okay, gluten-free diet. Yes, gluten-free diet is the #1 choice, and it should be with supplementation. Okay, so dietary supplements to correct the problems that the deficiencies that were there until the problem is fixed. Okay, so gluten-free diet, lifelong. A lot of patients would like, okay, when I get better, I will get back to eating gluten. You would tell them no, and they would do it anyways. So we need to be careful of this. Okay. And be careful of cross-contamination. There are some foods, some things that are not foods even, which may have some gluten in them. So you need to be careful. Even toothpaste is one of them, for example. It may have some gluten. It may get in, disrupt the patient. So you need to be careful. That's herbal tea also has it, but coffee doesn't have it. That's another reason why coffee is better. Anyway, if you know me, you'll know why I said this. Okay. You will find that there are some of the extra-intestinal manifestations which can be fixed by supplementation. For example, there could be some patients who are coming with purpura or bruising. That's because of vitamin K deficiency. Some neuropathic changes due to B12 and folic acid deficiencies, iron deficiency anemia because of iron deficiency, of course. Severe muscle weakness could present in an acute stage. You need to supplement them with potassium, even as an IV fluid, okay? When they come like really late and in a really bad state, or they have eaten like a huge gluten-rich meal. Then you have calcium and magnesium for tetany. Again, that's related to the muscle problems. For children, if you remember, we said there is rickets. We also said there are other bone problems with osteopenia and osteoporosis. We need to increase calcium and vitamin D in order to fix this. And this is, I believe, the last question for celiac disease. Which of the following is the treatment of choice in refractory celiac disease? Aside from, I'll let you choose. Okay, come. Okay, but there is something different. Okay, assuming we have done A or B, it's still a problem refractory. What would you add? Is it C, D, or E? D? No. It is C, yes. So glucocorticoids are not usually indicated. However, they are reserved for refractory cases, okay? These are some severe illness. Again, like we said with the severe muscle weakness that we talked about. Okay, moving on to the lecture before the last lecture. PUD drugs, peptic ulcer disease. Again, Maram discussed it in details. Sketchy. Okay, this is Helicobacter pylori, okay? Sketchy is really good, guys. Okay, don't skip on it. I vouch for sketchy. Okay, I used to be a sketchy hater, but now I like it. I vouch for sketchy pharma and sketchy micro. Anything else? They can go to the garbage, okay? Sorry. I don't know why this is empty. Question 1. Patient presented with chronic peptic ulcer disease, okay? I'm sorry with the abbreviations, I will let you know. But you know some of our doctors like to use abbreviations a lot without showing them. So PUD, peptic ulcer disease, ER, emergency room, CAP, community acquired pneumonia, okay? Patient presented with chronic PUD, ER, CAP, magnesium levels are low, there is peripheral neuropathy. What drug was the patient taking for the PUD? Okay, so we're asking about side effects here.
Magnesium hydroxide.
Serum magnesium levels are low. Come on.
I don't know, D. I think it's D. Either D or A. What's that?
Yeah. You guys, are you stick on something, guys? E?
Yes.
Everyone says E?
Yes.
It is E. Yes, because that's a sketch for PPIs, okay? There is a lot of bad side effects if you go with a long-term PPI course. We need to be careful of some of these which are highlighted. Thank you, Dr. Mohamed Salah, you are the best doctor ever, okay? I may be a bit biased. Clostridium difficile infection can be increased. CAP can be increased. There are even worse adverse effects, which include bone fracture, vitamin B12 deficiency, and there are some others as well. But these are the ones that were discussed in the lecture, okay? This sketch may help a bit. Question 2. Patient in a region with Helicobacter pylori antimicrobial resistance rate of 39%. If you read the lecture, you will know I put this. Presented with HP positive PUD, okay? Which drug regimen should be administered? I'll sit down here while you read this because it's annoying. There is a bit of a trick in this question. Be careful, yeah.
We don't remember.
Do you remember?
Resistance should be less than 40%.
What is the 40%? 20 or 40? I'm not sure.
20.
Are you sure it's 20 or 40?
I don't even know the regimen.
That's why I put 39 because I like to be annoying. It's 20. Okay, so it's okay. I'll give you a hint. It's 20, so it's in a highly resistant place. Okay.
So
quadruple therapy, bismuth-based quadruple therapy. So which one here is with bismuth?
I think A.
A, right. You will notice here that I put metronidazole. Okay. And the second one, if you know what this one is, which one is the second one? This is a quadruple therapy, but okay, just a quick thing. The doctor asked about it before. In this one, this is a quadruple therapy, but there is a specific name of a drug. It's a commercial name, but the doctor like emphasized on it. He talked about it in the lecture. If I remember, we got pylera, yes, if I remember correctly, we got a question about it. That's because of the specific concentration of it. But it contains all three of these except the PPI, which should be given like separately. For B, do you know what B is?
What? B is for sequential.
No.
No?
sorry. What is B? Come on.
Which B?
B, metronidazole, 500 milligram twice a day. Ignore the dosages. Effective assessment. You will not be asked about dosages. I hope. Yeah. Metronidazole, clarithromycin, PPI. Triple therapy. طب why is this? طب هنا شوفوا the next one. Amoxicillin, clarithromycin, PPI.
That's triple
B
therapy.
is something like.
C is triple therapy.
It's B or C triple therapy.
C is triple therapy.
طب what's B?
Sequential.
لا.
Alternative something.
Yes. They are both triple therapy.
Penicillin allergy?
Yes, they are both correct. They are both triple therapy, but we use metronidazole here because the guy has an allergy, okay? Final one here, amoxicillin twice a day, levofloxacin, that's the salvage therapy. We don't use levofloxacin a lot. Why? I don't know what happened. We have gotten some spoilers here, so ignore this. No one saw anything, okay? Where did I go?
Because of
Yes, salvage therapy, because of resistance, we don't use levofloxacin, okay? Bismuth-based quadruple therapy, tetracycline, metronidazole, bismuth. PPI, pylera is a brand name, again, it's highlighted here, okay? Remember pylera. It's the only brand, one of the only brand names you will want to remember, okay? Again, first line therapy is bismuth, the quadruple therapy is the first line for places where there is 20 or above % of resistance. Below is triple therapy. Question 3. A patient with epigastric pain prescribed with vonoprazan. Okay, that's a really important question. Which of the following best describes its method of action? Okay? It's a really important question that a lot of people got wrong. I don't know why, but yeah, okay. Are you sure it's A?
No. G.
It's A and it's A when a lot of people discuss, but it's not A. What is it? What is it here correctly? G. Is it G? Are you sure it's G? It is G, correct. Because these are the drugs that the doctor talked about. They are pretty recent. PACad's potassium competitive acid blockers. Okay, they bind reversibly to potassium ions. Yeah, this one was pretty recent. November 2023, FDA approved. Rapid bad decisions, okay? Okay, patient wants an abortion. Which drug can be given, but you shouldn't give to her, of course. You all agree it's misoprostol? Okay, maybe you saw the slide I showed before. Misoprostol, okay. Misoprostol, that's a really important part. It is aborifactor. Okay, so basically it can cause an abortion. Okay, be careful because of its activity as a PGE1 analog, it can increase uterine contractions. That's why we need to be careful. This is also an important part for no particular reason. It inhibits basal and nocturnal acid secretion. Okay, keep that in mind. Patient with diabetes mellitus who presents with diabetes mellitus. I don't know why I put this. Okay, PUD. Okay, which drug should you remember to avoid as much as you can? Okay, he has diabetes mellitus. Which one should you avoid? D. Sucralfate, right? Okay, sugar. Okay, just remember it like this. But there is another type of patient which you need to avoid it in. Which one is it? Chronic renal failure or on dialysis, okay? Don't kill your patient, please. Okay, and there are some other details here again. Antacids, they work with a lot of drugs, they ruin their absorption.
Yes.
Okay. A patient with multiple medical problems is taking several drugs, including digoxin, iron supplements, fluoroquinolones, and ketoconazole, okay? You know what ketoconazole is? We will discuss it later in year 3. The patient recently suffered from heartburn. Which of the following medications will decrease the plasma concentrations of the drugs above due to interaction with the previous drugs?
Decrease the
على طول, by the way, when you think about it, okay, I didn't think about it that way before, but smash, okay, but it's not this. لا. What is it? Mm. Mm. Try to think about absorption, complex formation. You remember fluoroquinolones? What happened when you drink milk? A, right. It's antacids. Antacids can, here, I just took it like this, okay? Antacids can ruin the absorption of many drugs. You need to be careful about this, okay? That's why we generally say, like, avoid them, avoid taking them with other drugs, regardless, by at least 2 hours. Question 7. A 78-year-old female sees her primary care core physician for with complaints of heartburn. Her history includes only hypertension. She lives on a fixed income and has no prescription coverage. Okay. Her doctor recommends over-the-counter OTC antacids to be used regularly. So ignore all of this. She just uses antacids, which would be a good choice and why. It's a bit indirect. If you want me to cut you some slack and cut some of the answer choices. Okay, it's either D or E. Which one is it?
I remember aluminum causes constipation.
Which one causes constipation? There are 2 that cause diarrhea, 1 that causes constipation.
Aluminum constipation.
Aluminum and calcium carbonate
Yeah.
constipation.
Magnesium is diarrhea.
Yeah, my bad, I flipped. Okay. 1 diarrhea, 2 constipation. Which one is for the diarrhea?
Magnesium.
Magnesium, right. So, which one will it be, D or E? Alright, again, as I said, diarrhea, magnesium, constipation, aluminum, and calcium, okay? I'll try to go a bit quicker. 63-year-old male with long-standing, poorly controlled diabetes again is administered for yet another episode of ketoacidosis. He had once before. He's out of the ICU, beginning to eat. He complains of regurgitation, even after small meals. That suspects the development of diabetic gastropathy. Okay, it's a neuropathy thing. Okay, so there is a problem with movement of the gastric content. What would you expect? What drug would you use here? Do you all agree it's metoclopramide?
Yes.
Okay, another question. What was metoclopramide doing? How did it work? What was its MOA? Okay, it's a D2 antagonist, correct. But there was another one that's a D2 antagonist. Be careful, don't parry it on as well, okay? But I don't think the doctor would bring the same one question. They're both in one question. Isanicol, that's another one. It stimulates muscarinic. If you try to link it a bit, what would happen if you stimulate muscarinic receptors? I think I didn't include it in my explanation, but hear me out, okay? So, okay, that's one thing, but when we are talking about GERD, forget GERD, like peptic ulcers, GERD, peptic ulcer disease, yeah. Secretion, yes, okay? So here, why are we using something that would cause more problem? Isanicol is like the least problematic one of the antimuscarinics, okay? I mean promuscarinics, sorry. So that's why we use it. Patient presents with Zollinger-Ellison syndrome. What is the method of action of the best drug of choice? It's pretty straightforward. It's also a really important question.
It's
Correct. It's, PPIs are the primarily used, omeprazole or a similar PPI. And of course there is other treatment like removing the tumor if it's removable and stuff, the other things with Zollinger-Ellison. You all know Zollinger-Ellison syndrome? You remember it?
yeah.
Okay. Question 10. Which of the following is a known side effect? Which of the following drugs has a side effect of tongue and stool discoloration? One of these. C, yes. How does it discolor them? What does it do? The drug looks pink, but it's a bit dark. Yeah, more towards the dark side. Yeah, this is a pretty popular drug in the US, at least that's what I know. Pepto-Bismol. And since recently they didn't know a lot about how it works, by the way. And you need to know it has antimicrobial activity. So, like, don't think it was in this specific lecture, but for example, if someone is traveling and they need to, a protection against traveler's diarrhea, sometimes they can give them this. The last lecture, يلا هن جماعة. IBD drugs, okay? Question 1, rapid, okay? A patient with a history of IBD presents to the ER with orange discoloration of the skin and urine, yellow-orange discoloration. And there are renal stones. Which of the following drugs may have been the case? The cause? Saladin. Okay. Do you all agree it's sulfasalazine?
Yes.
Yes. It's important to know that there are other drugs in aminosalicylates, but this specific side effect is specific for sulfasalazine, okay? The urine discoloration and stuff. The skin discoloration and urine discoloration. And this is life-threatening side effect, so we need to be careful of. Okay, a patient with a history of refractory IBD presents to the ER with IBD is irritable bowel disease, inflammatory bowel disease, sorry. Long course of hemoptysis, weight loss, fever and night sweats. Year 3 know what is this. For year 2, I don't think everyone would know, so it's I put the diagnosis here, reactivated latent TB, okay? What drug is really important here? Okay, so infliximab is a TNF-alpha inhibitor and it has a black box warning. You need to screen, you need to check if the patient has latent TB before putting them on this drug. If they have TB and you need to use the drug, treat them from the TB, then use the drug, okay? It can be really, really bad. Patient, okay, someone read, because you are a bit sleepy now. I'm a bit sleepy. I slept only 4 hours a day and it was pretty bad. Come on, who would like to read?
Patient presents with incoherence to refractory to treatment. They were prescribed a drug that binds molecules responsible for differentiation of naive CD4 T cells into T helper cells, T helper 1 and T helper 17. Which of the following is correct regarding this drug? A.
Guys, who is here? I'll leave you more chances to answer, okay? ماشي؟
لا
سن.
ماري.
Okay. لا. You need to benefit. Rashid will not answer any question. He is already out. Interleukin 12, interleukin 23 in monoclonal antibodies that target them, okay? Ustekinumab, that's the drug, okay? A patient with a history of IBD again presents to the ER, but this time with severe cognitive deficit, and the diagnosis was PML, not polymorphic, my bad, progressive multi. What was it? Do you know?
Progressive multifocal leukocyte.
Yes. Okay. Thank you. Despite appropriate life-saving measures, the patient dies. Okay. Avoidance of prescribing which of the following drugs would have spared the patient? Which drug has PML? You answer. You answer. Natalizumab, yes. Correct. PML is a black box warning again. That's the second black box warning we have here, okay? Natalizumab. Be careful of natalizumab here. What does it say? It's an alpha-4 integrin molecule inhibitor, okay? Or it binds to it. There is another drug which can be confused with it. We will get to it, okay? Which of the following drug, key point, this is an important question, for both Crohn's disease and ulcerative colitis, is a small drug, okay, small molecule drug, that binds selectively and reversibly to ATP binding site in the JAK kinase. Okay. So it's a JAK inhibitor, but it works for both CD and UC. Which one is it? You would realize that I didn't put one JAK inhibitor here. I put more than one, so choose wisely. Which one is? B or D? No, not D. My bad. B or what letter is it? G. B or G? It's okay. So JAK kinase inhibitors, small molecules. They work on the JAK inhibitor. JAK is for kinase. K is for kinase. It's not B. It's G. Abatacitinib. Okay, abatacitinib. You know how I try to remember it? It's like a more new drug, and it works in both ulcerative colitis and Crohn's disease. So it's like updated. Okay, that's how I remember it.
This is new, I think. Yeah.
These two are also drugs that are JAK inhibitors, but they only work with ulcerative colitis. Okay. At least in clinical practice. We're almost there. Which of the following drugs acts by internalizing and degrading the S1PR1 and S1PR5 receptors? I? Was anyone? Is everyone okay with it? Are you sure? Correct. It's ozanimod. It's a sphygmosine 1-phosphate receptor in modulator. Okay? And it's pretty new as well. Okay. Question 7. Patient presents with severe ulcerative colitis. Treatment with TNF-alpha inhibitors and corticosteroids have failed. What is the method of action of the drug that should be used next? Really important question. Are you sure it's C? Okay, I will give you two choices. Choose between them, C or D. C? Are you sure it's C or D? C? Everyone agrees with C? Okay. Correct. It is C. Which drug was the one for D? Which one was the drug for D? We just covered it a few slides ago, guys. Come on. This is alpha-4 integrin molecule. But this one, it's an alpha-4 beta-7 integrin receptor inhibitor, not for the integrin itself. Okay? It's also new. It's called vedolizumab. Okay? And it works on both UC and CD. If you find it here, wait, let me bring it back. Here, the alpha-4 integrin inhibitors, natalizumab, only for Crohn's disease, not for ulcerative colitis. Here, it works for both ulcerative colitis and Crohn's disease. And with that, we are done with this long, amazing lecture.